Good afternoon, everyone. Welcome to the first Behavioral Health Echo session of year 2025. My name is Andrea, and I will be your facilitator during this conversation. Thank you to all of you for being here. And just as a reminder, this session is being recorded for later distribution. However, the information that you see on the chat will not appear on the recordings. So we invite you to continue identifying yourselves on the chat by adding your names, email addresses, and affiliations. This information will help us confirm your attendance to this class. And especially if you're part of our provider network here at BWell Texas, or if you're seeking CMEs, definitely we want you to identify yourselves. However, if you're joining via phone, you can always send us an email at bwelltexas@utesca.edu, and that way we can associate your names with your phone numbers. If you need captioning for this class, you can always navigate to the bottom part of our Zoom windows and click on the captioning feature. So in today's session, we're starting with a 25 minutes didactic presentation by Dr. Denis Antoine, followed by your questions. And then in the second part of the session, we're going to be discussing a case from one of you, from someone for our community of learners. And this is the part of the session where we encourage your participation. We want to hear your perspectives, your opinions. Please remember that these echo sessions are made for you, the learners. So it is very important that we hear your voices during this class. One small thing, before you participate, please make sure that you raise your hand and then wait until we call your name, and then you can unmute your microphones. And this is just small but important practice that will help all of us to have the same opportunity to participate in this conversation. And with that being said, we're going to start with our introductions from the Behavioral Health Hub of Experts. Katie Dundenville, nice to see you. Do you want to introduce yourself to the group?
Yeah, my name is Katie Donville. I'm a clinical psychologist at UT Health San Antonio, and I lead the Strong Star Training Initiative, which is focused on training mental health clinicians and evidence-based treatments for PTSD and suicide.
Thank you. Dee Dee Stout.
Hi, good morning from California, rainy California, finally. Thank you all for those prayers and good wishes. We need it. I am in private practice here in California, have been for a very long time, where I work with individuals, families, couples, as well as doing consultations and trainings to organizations, especially in motivational interviewing, but also in solution focus and trauma-informed work. What else? And I am adjunct associate professor at St. Mary's College over here in the East Bay in Moraga. Thanks.
Thank you. Asia, our case presenter.
Asia Olson. I'm an LCDC and an LPC associate with Coastal Bend Wellness Foundation, which is down in Corpus Christi on the coast. Happy to be here.
Thank you for being here today, Asia. Jasmine.
Hello, everyone. My name is Jasmine Vidal, and I'm the ECHO coordinator for our Behavioral Health ECHO. Thank you for joining us, and I hope you enjoy today's session.
Thank you, Jasmine. And Dr. Antoine, I think that whenever you're ready, we can start sharing your PowerPoint didactics, and you can take it away. Thank you.
All right. Thanks, everyone. My name is Denis Antoine, psychiatrist at Johns Hopkins Bayview, where I'm the director of the Center for Addiction and Pregnancy, and also the Cornerstone Clinic at Helping Up Mission, different angles of substance use disorder treatment for underserved populations in the Baltimore area. My goal today is to, really follow up on for those who've been in these sessions before, follow up on an angle that we talked about before. In this case, talking about AI, artificial intelligence for behavioral health, and looking at the benefits, consequences, and some of the unanswered questions. Unfortunately, there may be more unanswered questions at the end of this time than than I can answer, but this will give an overview as to what's possible as we move forward in this field, which is growing every day, as I think, as we talk even now. So as the standard starts, have the disclosures for the ECHO program. I don't have any conflicts for this talk, but I'll talk about some things that are coming more and more that could represent conflicts for other persons who deal in this area. And objectives here are to examine the ethical implications and privacy concerns with AI and behavioral health, and also develop practical strategies of how to include AI if one is willing or wanting to in behavioral health services, and then evaluate the acceptability and receptiveness of AI within the process. Because I think that's one of the bigger keys that we want to look at in this space. And I'm looking forward to actually the questions and thoughts at the end of how this can be applied in different person's areas wherever they're working. So starting out, and this is where I actually left off a few months ago, which led to further questions that generated this talk. One of the things that we've done in my clinic over the past few years, especially during the pandemic, was to expand telehealth. And I think it was helpful for us to maintain what we were doing. We were separated from people due to social distancing and many things, and telehealth took off. Parts of this article that I have here showed that there was almost a 30-fold increase in telehealth utilization. And that's something people had to really take advantage of and take into account. However, if you read within the lines of it, the conclusion and the relevance at the end, it really does say it reflects a higher capacity for providing health services in the areas where the intensity may be reflected. Now, the question from there is who's going to provide that higher intensity? Who's going to provide more of that? Because unfortunately, what we've seen is there haven't been a gush or a huge increase in the providers that are providing this work. It's just we have a way now of reaching them a lot quicker. And this begins the conversation towards where AI comes in. One of those things, and I would assume many people on this call may have felt it at some point, is that burnout has been a long-standing problem in behavioral health. The estimates range from between 21 to 67% of people who felt burnout, especially during the COVID-19 pandemic. And it's disproportionately affected persons of color and individuals who've had to work in underserved areas. So that's something that says, how do we solve this? How do we account for this? What resources are available to help these individuals out to do the work that are really the work that is growing and has much more need over these past few years. From there, that's where you think about what is artificial intelligence, because it has a really broad, I think, definition in its use right now. But the core of artificial intelligence, as it is supposed to be, it's a theory and development of computer systems that can, quote unquote, do things that normally require human intelligence. That is a debate. I'm expecting to see a lot of comments and questions about that, but that's the intent of what this is supposed to be. And those human intelligence, again, quote unquote, are things like visual perception, speech recognition, actually making the decisions, and then translation between languages. Now, there are a lot of apps out there for Google Translate and other things. So, I don't think that we're simply talking about translation between languages for behavioral health. It becomes a question of how do we use these other aspects of human intelligence to help us out in certain ways. And that's where the conversation starts. Again, burnout could be one of the things, but how could this be helpful for the individual providing the service and the person receiving the service? And this schematic, I won't break it all down, but it's what people say is the ultimate way this should happen. Patients or clients would start at the beginning, and there would be multiple layers of information through devices or labs or recordings, computers, even facial and spatial recognition, speech recognition, that would be boiled down into these algorithms that would do everything for us in terms of treating depression, treating schizophrenia, whether it's ADHD, addiction, whatever it may be. People are saying this is how it should go. We are nowhere close to this. This is not where things could be right now, because all of these layers, especially the technology for facial recognition, may not recognize the face or the speech correctly. And the way things are mimicked or affordable for the devices and the examinations. All of these things are barriers to making sure all this flow happens correctly. But it is a way that people envision that intelligence could be mimicked. A lot of barriers there, but the question is where are we now with this? And one of the examples I put out there is an article that was a research study that was done to show, can it be used, by helping out with clinical supervision. When I came through my training, we used to have these tape recorders that we would sit down with our clients and say, I'm going to record this session and I'm going to record it and I'm going to, bring it back to my supervisor and we're going to listen to it together. And the supervisor is going to give me feedback as to how I can improve. And that's how things were. I won't say how long ago that was, but that's how things were in the past. Now it becomes a question of, can that recording be automatically interpreted by a computer to say, am I providing motivational interviewing or some type of structured approach in the manner in which it's supposed to occur? And where we are with that is, those things are being tested and tried, and some of those are shown to be effective. This article points to one example, but that's a possibility of where this could go. Again, helping that supervisor out so they don't have to spend all that time listening to the recording, giving the provider or the trainee instant feedback. Some of these trainee programs actually change the color from green to red if you aren't doing the right thing, and then change back to green if you're doing the right thing, giving that automated feedback, which saves some time and keeps a person in line with a standardized practice like motivational interviewing. That's one example of the possibilities. Other possibilities are out there, and they're being employed steadily. Scribes are one in particular that, from my standpoint, I have a history of dyslexia, so a device that can automatically take notes and write things out for me is very helpful. Again, you would need the permission of the client to sit down and say, hey, I'm going to take notes through this device so it can record and it goes into your electronic record, but it can automate that process, again, decreasing the burden and making it a bit easier for the provider to do what they are hopefully just trying to do based off of their practice. Other examples would be remote monitoring, taking vital signs from a person's home and transmitting them to a different space and giving feedback as to whether it's high or not. Toxicology screens, and then there's something a little bit more invasive, which is ecological momentary assessment, which really just means it tracks each moment when you're having an activity, whether you're having a craving or whether your heart rate goes up higher. It can trigger an assessment in that moment to say, how are you feeling? And sometimes even automatically give that information to your provider right away. That can be a bit invasive, and you can see the different layers of how this could occur. A lot of it does require the input and the acceptance of this by the client who's receiving this information or giving this information over. We just received the publication acceptance yesterday, so I didn't include it in this talk, but there is a growing amount of clients and individuals who receive services who are open to this type of information being spread amongst providers, but it's very important to understand how the privacy of that information would be kept. So that's a big caveat as all this comes through and all these examples happen. Privacy and the acceptance by the clients is very important to figure out. I don't think we've fully done that yet. But beyond these examples, there is a downside that I would say. If you've noticed, I haven't put out any products in particular. From a CME standpoint, I want to keep this as unbiased as possible. And many of these AI machines or softwares are highly commercialized. And that means it's difficult to sometimes give an unbiased approach as to what's the best product, because it sometimes is what's first available. So there should probably be more scrutiny as to what's going on with each of these and whether it's solely a commercialized product or has it been tested from a randomized controlled trial to see which is better, this product or something before that. And with the commercialization comes the affordability and the potential for reimbursement for these things. Just because they're used doesn't mean they're going to be free to use and doesn't mean everyone will have access to them. Sometimes you may need a device or a smartphone, which may not be affordable for everyone. Many of my clients that I work with don't have the data plans or the access to those devices to benefit from this. And even if I do as a practitioner, it doesn't mean I can sustainably use it because I may not get reimbursed, and those costs usually are recurring to be able to afford this type of machinery to chop everything up. At Hopkins, I can say we did just roll out scribes for many of the providers, but there is a sect of the counseling staff that does not have access to that due to cost. And that's something we're trying to grapple with right now as well. And then there are the algorithms, and that's something which, you could probably go on for about an hour just in and of itself on that. As I mentioned in previous slides, these AI devices and softwares, they take a lot of information and put them into this formula to say, here's what's going on. And the term GIGO, G-I-G-O, means garbage in, garbage out. And you could have that difficulty with a lot of these different software capture or data capture devices, whether it's what I've experienced in the past myself, a camera maybe taking in the wrong facial data based off skin tone, or taking in the speech difficulty because of an accent of some sort, and then coding that a certain way. Some of these scribes have even pointed out that they have hallucinations in which they write out things that did not occur in the conversation. And that can lead to a lot of difficult issues there, whether it's the garbage in, the garbage out, or if AI says, well, here's the epidemiology of what's going on with this condition, it may not be based off the whole data set of what's happening in the United States, just what was fed into that database. So that is a downside at this stage of AI that definitely needs to be worked out. And I would say we shouldn't fully rely on this as the way of how to deliver care. But it could be a tool that could be helpful in easing certain burdens along the way. Accessibility, though, is a big thing. And this study really shows that, again, telehealth is the way to increase access. But with all of these things, whether it's telehealth, AI, we need to think about almost what is the basics of digital access this day and age. How do people engage? How can they do it sustainably if they don't have the devices, or if the digital literacy is very high, the requirement is high to use these machines and the software and this AI? It's a big question that I think we need to think more about, because now it's not just about accessibility to getting to the provider, but really getting to these tools which could be helpful. One suggestion, I'm giving a bit of a preview to the case, I think, is some of these devices could capture how a person's mood tracks over time. So they could have a sense of whether their thoughts are getting better or worse, their feelings are getting better or worse, and they can reflect on that before they come to the provider and give an overview, or the provider can see a timeline of how a person's mood or thoughts maybe vary over time and have that ready for them when they walk into the session. And that can be helpful. But without these digital access issues resolved, the literacy resolved, that possibility of foreshadowing or making the session as efficient as possible might be lost. So I think that's something we need to think through. I even had a meeting a couple hours ago how to get my own staff here iPads so they can do that with the staff that the clients that we have here in the clinic. And there's a lot of operational issues that go into that. Now, my final slide here, I'll go on for a little bit. I use this one often, but I think it does come back to where we are when we're talking about AI and how we deal with people with certain situations. You can imagine a person who has high anxiety or trauma is trying to walk across this shaky bridge. And I've often referred to this as the shaky bridge of traversing mental life, really, and trying to get to the other side where a person feels better. When you apply AI to the situation, the question is who or what is now walking with that person across the bridge? If we're talking about a practitioner, we're used to a person holding a person's hand and walking across and making sure, as Jerome Frank said in Persuasion and Healing, that that person is important to the other person, has some type of meaning to that person. So it's a comfortable and easy walk across the bridge as much as possible. The question now is with AI, is that engaging enough? Is that computer or that software engaging enough? Does it give that same feel to mimic not only human intelligence, but human emotion? I don't think we're there yet, but that is what people are trying to do. Will I say it's helpful for writing my notes? Yes. Will I double check and double read those notes to make sure there are no typos or no issues with the notes? Absolutely. And given that I have one of the largest telehealth clinics in Johns Hopkins, I need that to keep up my volume. But I do that so I can tell my clients, hey, I just want to have a conversation with you and not have to worry about taking notes during the session. And that allows me to be a bit more engaged during the process. The computers aren't there just yet for that. And I would argue in this day and age, and hopefully for the future, they won't get there. But that's where the conversation starts. So here are my references, and thank you for the time. Like I said, I look forward to any questions folks have.
Thank you, Dr. Antoine. That was a beautiful analogy, that shaky bridge, but we don't know who is walking with us through that bridge. I like that. And let's open the floor for some questions and comments from the group.
I thought it was a great talk, and I thought it was a great question. Like, who is actually walking across that bridge with someone undergoing therapy? And I think anyone who's used AI, um, for therapeutic purposes. For example, I use it to augment what I do. I use it to review my cases and to basically act as a colleague who is taking a look at it. Now, when you actually have the AI being the therapist, if you will, or I'm not really so sure. I mean, what I see from the AI, where we're at today, I, I don't think we're there yet, but I can't see the AI the way that it is. I mean, I see it as almost like these phone trees that we have to navigate, or the AI that asks us, ask me anything, I can help you. And 99% of the time it's like customer service, human being, because the AI doesn't get it.
Great points for sure. Yeah, no, it's intelligence evolves. I'll say that. And folks from the '90s who've seen Terminator, not to put that out there, it's Skynet evolved. I don't know what the reins are on this intelligence to evolve, but it's not to the point where it's competing with the expertise on this call for sure. All the individuals here, I think, do great work.
Anyone in the group who wants to share their experiences with AI so far and how helpful they feel they are in their own practices or in their daily tasks.
I actually use it pretty heavily, and I've seen it save lives, literally. I deal with cases where there are, literally gigabytes of data associated with a patient who comes in for the first time in 6 months after being hospitalized in facilities, and it'll pick out a lab where the patient has rhabdomyolysis and but it's only in the hands of a skilled pilot, if you will. An aircraft can do wonderful things and take this entire group on a vacation, but by itself it can't do that. And in the wrong hands, we could see what happens from the news. So I think it's a double-edged sword. My own background, I have engineering and medicine. I used, I would run chemical plants or semiconductor factories with sophisticated computer systems. So I'm very comfortable with that. But, not everybody has that comfort or even that desire to deal with all the problems that come with that. So I think it has potential, as the comment was made. And literally, I've seen it save lives.
Thank you. Yes, definitely AI, something that we're all looking forward to use more, especially in healthcare, but there is the training factor. You have to also train the people to use AI effectively. Otherwise, as Dr. Lubner just said, we are in the same place.
Yeah, I'd agree with that. And, I find it to be a colleague to say, hey, do this for me, read this and tell me specifically this. I wouldn't for relying it like the advice from Dr. Luckner or from Dee to say, what do you think AI? I don't think it's there yet. So it's a really good augmenter, a really good colleague for certain things. I see a question from Lindsay, so I don't want to take the time.
Oh no, I was just gonna say that like I think it's the other part that's been really helpful for me is in like grant writing and stuff, like getting some of that language down has been really helpful. Or and also writing like mission statements and things for organizations and stuff.
Definitely.
Fully agreed.
Yes, absolutely.
I can see one of the challenges too. I mean, it's somebody who's in private practice at the college, we might have certain access or availability of support and training, but in private practice, how are we going to afford that? And oftentimes, you're right, Dennis, that the clients that we're working with that might have a severe mental health or addiction process, we're lucky they have a cell phone. It's and it may be a pay as you go, so it may not be capable of even having some apps on it, although most of them can do that much. But yeah,
Absolutely, and the privacy of what you can afford at the lower levels is difficult because AI is a big database of its own. Hospitals and health centers have to really jump through hoops to segment that data from everything else, and I don't know if the private practitioners or the individuals with let's say, the government phones would have that segmentation of their data, which is a big issue.
by the way, the program with motivational interviewing is called Listen, Lyssn. I can say it. And it has proved to be pretty darn good. A lot of us in the motivational interviewing network of trainers have used it or are currently using it, particularly with larger organizations. Because again, you have to have a certain number of people to be able to afford it because they don't have it at a just simple practitioner level yet. I've talked to them.
I also see Kim Williamson has a comment on the chat. Kim, would you like to unmute and tell us a little bit more about that?
Well, really related to what Dr. Stout was saying about, we're working in rural areas and sometimes we even have to drive out to see the person face to face because they don't have cell phone reception. We're in rural and frontier areas in the hill country in Texas. But also, this is all just so new to me. I'm learning so much about, and I work with a local mental health clinic provider, so we're nonprofit, and I didn't even know under what circumstances we would be allowed to use any kind of AI or what it would even look like. So I'm kind of like starting at the bottom tier of this whole AI platform.
And that makes sense. The more general term people are starting to use and have used for a while is digital therapeutics.
Okay.
Not to say that again the digital stuff is going to do the therapy for you, but even those old mood trackers that people used to say the smiley face, circle that's on a phone now. Some of the more basic apps, and having them show you what we would used to call the timeline follow back of your smiley faces would be AI just on the phone keeping it rather than putting it on paper. So there's a wide range of what AI is, but some of it could just be, hey, keep track of your mood, my mood for me, and that's where I think it could probably start to keep it easy for some of the folks who don't have as much tech access.
Oh, that's great because I do use that for clients who have smartphones. And, I offer these free apps that they can look up, like for meditation and sleep. Is that considered AI?
It is. Is it randomized controlled? No. But will it suggest certain ones based off of what they use? Yes. Again, not naming names, but yeah, it sounds like you're using AI in certain ways. You just don't know it yet.
Didn't know it. There's Carrie, my colleague. Okay, thank you.
Thank you, Kim. Anyone else? Questions or comments or experiences? Carrie.
Yes, I guess I'm really excited about the opportunities that may come in the future. I again work for Hill Country, which is a nonprofit, and I work in the substance abuse field. Um, my concern is even at this point, there are so many different people. I work virtually. So I work in a rural area where 75%, I would say, of the people who live in this area are below poverty level. Even having cell phones is a big deal to them. And there is really a learning curve to even learn how to get on to the platform of, let's say, Microsoft Teams, where I have to train them how to get on so that I can meet virtually with them. I guess there is a bit of fear of, I'm older and my technology may not be like, I may not be tech savvy. And if I can barely help them get onto Teams, what would that even look like with other avenues?
Yeah, it's a very interesting question. My family's from a Caribbean island that's near to where Hurricane Beryl swept through. So we've been dealing with that. Like, how do you access the technology? How do you even set up a Zoom for these folks? I think you have to just start with what people are comfortable with. And you can't stretch them. Otherwise, you're shaking that bridge even more as both people are walking across, and that's not what you want. So, I think the practitioners just have to say, this is what I can do. I can do it well, collecting faces, doing meditation in a room, and that's what it's going to be. And I think that's where we have to start. If things like there's a HRSA grant right now that people want to apply for. It's due by the end of March or beginning of April for a HRSA award to study different ways. That's what we have to do to advance the ease. What I had to do in my clinic was literally make the icons for the staff and for the clients and put them on their desktops myself. So it's just a double click.
I guess my other concern that I would have too is having a lot of people that I work with are very much, there's a lot of meth, which comes along with a lot of there's a lot of different paranoia, issues of that kind of concern, where even getting on video is something that can trigger them.
Yep.
Do we have any ideas of how to even do or work with that?
I'll be blunt. No, I don't. I think they're developing digital tools to listen in and say this person seems more psychotic, if you will, or disorganized. They're developing that. Definitely for suicide, those are algorithms that they're trying, but these are algorithms. And I do think there needs to be more work. We did work on the acceptance of these tools and electronic medical records, just in individuals that are doing substance use disorder treatment, but for your population with folks that have more maybe schizophrenia-like symptoms, I think that work does need to be amplified a little bit more.
Thank you, Dr. Antoine, and definitely a fascinating topic. And we may even have a second part later on the series. In the meantime, we are going to be moving to the announcements so we can have enough time to discuss a very interesting case that we have today. So Taylor, whenever you're ready. The Center for Substance Use Training and Telementoring CSTAT offers technical assistance. This is a free service for all of you in the community. If you're interested, please go to our website, that is cstat.utesca.edu/contact. There is a form there for technical assistance. Someone will get back to you in approximately 3 days after that. Next. And if you want to claim your CEU credits today, you know what you have to do. Just answer your post-session survey. We're sharing it with you right now, and we'll also send it in an email after this class. And on the question, are you applying for CEU credit for today? Just answer yes, and you should be receiving your certificates in approximately 3 weeks. Next. And we're still conducting a very important, interesting study here at Be Well, Texas. If you're interested in taking part on this study, just send us an email here at bewelltexas@utesca.com. This study is a parallel intervention examining the Kiosk app, great app for persons who are using substances and are currently taking buprenorphine. Next, please. And this is for our webinar, the Thriving in Substance Use Disorders Service Delivery in the Post-COVID Era webinar. This is a session specifically on mobile integrated health emergency responses to substance use in COVID-19. Please join us. That's Friday, February 7 at 12. Next. And remember, we will not have a behavioral health echo in February because all of us and all of you, hopefully, we're all going to be at the conference. The Texas Substance Use Symposium is in February, and we'll all see you there. But we'll meet you here in this space again in March. Next. The Texas Substance Use Symposium, as I was saying, is here, and you still can join virtually. Please go to texas.org. That's our page if you want to attend to any of our virtual classes. Great opportunity to mingle and network with other professionals in the field. Next. And if you or someone you know is interested in becoming a sponsor or exhibitor, we still have a variety of sponsorship and exhibitor packages available. Please go to texas.org/sponsortexas, and we'll give you all the information there. We'll see you at the symposium. Next. And I think we can start sharing the case form, Aisha, whenever you're ready. If you could briefly walk us through the case. Perfect. We can, exactly, a little bit bigger. That's it. Thanks.
Thank you. So this client is a 42-year-old cisgender Hispanic male. He came to see me in September of last year, and we've been meeting weekly since. He came due to methamphetamine and cocaine use disorder. And while he's doing very well with his sobriety, he has not used since we started working together. He continues to struggle with intrusive thoughts that he might be gay. An important cultural consideration is that he is very close with his mother. He grew up, mother and father still married. They are both very devout Pentecostal Christians. And so he grew up with a lot of kind of programming that homosexuality was sin. And he was also sexually molested when he was 7 by an older male cousin. So there's some trauma there that we've worked through. However, he has had these intrusive thoughts that he may be gay and that he doesn't feel like he's gay. It's just this ongoing intrusive thought. He'll be with a group of people, a group of friends. He's been going to Recovery Dharma weekly, like twice a week. And he wants to socialize more, but these thoughts that he may be gay kind of act as a barrier to him. They cause him to have like severe low self-esteem, he struggles with confidence. He states that he has no desire to be with a man, though these thoughts just continue to come and keep him really feeling like he's in prison. Those are his words. He actually is on disability because the thoughts were so severe that he called the police on himself and told the police that he was he had this delusion that he was like molesting children, which he wasn't. And so eventually he was able to receive the disability funding, which is basically what he uses to live on right now, though he does still live with his parents. Let's see if I can go through this. I've used acceptance and commitment therapy with him, and I've also just done my own kind of research on what's called homosexual obsessive compulsive disorder. I had never heard of it before, but he filled me in because he's been researching this for many years, and trying to figure out how to stop the thoughts, and which is why I really thought that acceptance and commitment therapy would be appropriate, because it's not about stopping the thoughts, it's more about accepting that they're there and focusing on what his values are and moving towards those. He has a lot of strengths. He is very motivated, he's kind, intelligent, very self-aware. He's a caring father. He has a 2-year-old little girl who is currently with the mom, but he has visitation and he sees her regularly. I've also used relational cultural therapy with him just to kind of help the trust, because he's been through several counselors, and his words, no one has been able to really help him with this specific issue. So that has been, I think, helpful. I've also really tried to focus on his strengths and build on those. What else? His goal is to manage his thoughts. He talks about how these thoughts are really why he was using. He was basically trying to get away from these thoughts, and the substances helped him do that, specifically stimulants. So yeah, any ideas? I would really appreciate in my continued work with him. He is still seeing me weekly. As I said before, has not used meth or cocaine since we started working together. He is prescribed naltrexone and Wellbutrin. I realized the case states fluoxetine, but that was discontinued, and he's currently on Wellbutrin SR and naltrexone and Seroquel at night to sleep.
Thank you, Aisha. We're opening the floor now for questions and comments.
Great case presentation, and I know you're really doing a lot of great work with this individual. So I appreciate all the questions, and thanks for that update about the Wellbutrin. That's actually a key one that I'll come back to at the end. I may have missed it in my brief read here. Any current relationships to speak of for this individual?
Oh yes, he dates. He has, since we've been working together, he's dated a couple of women. Actually, he just completed his CPS classes. That was part of another reason why he started coming to see me. His child's mother went to treatment, and then he started seeing me. And yeah, so yeah.
And Kim Williamson was kind of echoing where I was going as well, in terms of what are his views, values regarding sexual gender identity in general. So what do you think?
He says, like, I have no sort of prejudice against. He states he does not share the same views as his parents, and that he is not a Christian. He's more agnostic. As I said before, he's been coming to Recovery Dharma, which I facilitate. And he's very interested in meditation and breath work. He recently started a yoga practice. he's very much motivated and wanting to learn and grow and change. And this issue just keeps creeping back in, and he's fearful that it's going to cause him to relapse.
David.
Yeah, thank you. So I have a situation that it's very anecdotal. It's not at all clinical, but it's just a little story that might be relevant. I was working with a guy, not in any clinical way. I was his sponsor in Alcoholics Anonymous. And at one point, after I've been working with him for a while, he came and he told me he was afraid that he might be gay. This was a guy who was married. He was separated from his ex, from his wife, had 3 children. He dated women. And I asked him why he thought that. And the only reason he gave was because one time when he was 10 years old, he and a sibling had been fooling around with each other and so on. And I just had this inspiration. I said to him, do you ever look at pornography? And he said, oh, yeah, all the time. And I said, do you look at gay pornography? He said, no, never. And I said, well, that might be a clue.
Yeah. Yeah.
Didi.
Yeah, thank you, Asia. This reminds me of a couple of clients that I've had. I will appreciate the information and how tricky it can be and complicated. I guess I have a couple of things. One is a question: why is he on naltrexone?
Good question. I guess it was prescribed for the cravings.
But naltrexone is used for cravings for alcohol or opiates, and I don't see either of those.
Yeah, no, he has no history with being
Yeah. Okay. Thanks.